Good morning, everyone. The topic for today's presentation is critically evaluate retraction cords and soft tissue management. These are the contents. Coming to introduction, the patient's mouth is a challenging environment to make an accurate impression. Moisture control is an important aspect of successful impression making. All the elastomeric impression materials, except for polyethers, they are hydrophobic. So, presence of any moisture results in voids. Therefore, saliva flow into the area must be reduced and diverted to obtain a necessary dry field for operation, and any bleeding must be controlled in order to obtain an accurate impression. Coming to tissue management is a critical aspect of impression making. It helps in recording the finish line. Also, it provides adequate bulk of the impression material between the prepared tooth and the gingival sulcus, which prevents the tearing and distortion of the impression while removal. Now, what are the prerequisites of soft tissue management? The prerequisites of soft tissue management are three. That is, first, tissue health. Second is the saliva control. And third is the displacement of the gingival tissues. Coming to first prerequisite, that is the tissue health. Now, minimal trauma should be done. Done to the gingival tissues during tooth preparation. Also, adequate control of moisture should be present because of any fluids near the prepared tooth will lead to the gingival displacement being rendered useless. So, the adequate saliva control can be obtained with the use of cotton rolls, saliva ejector, high volume evacuation, absorbent pads, whereas displacement of the gingival tissues is important for recording the prepared tooth, also for exposing the prepared and unprepared tooth surfaces. Coming to gingival displacement. Gingival displacement is the deflection of the marginal gingiva away from the tooth. This procedure is used to facilitate effective impression making with intraclavicular margins, whereas gingival retraction. Now, gingival retraction is a downward and outward movement of the pregingival margin away from the tooth. Now, optimum position of the tooth margin with respect to the pregingival margin is important. It is important for both the tissue health as well as the impression making. Now, the optimum position of the margin is 0.5 mm from the free healthy gingival margin and 3 to 4 mm from the alveolar bone crest. Coming to the biological width. The biological width is a physiologic dimension of the epithelial attachment and the connective tissue overlying the alveolar crest. Now, the biological width should not be evaluated during tooth preparation. Any violation of the biological width during tooth preparation or during soft tissue management will lead to increased chances of gingival inflammation, thereby leading to recession. Now, the critical circular width that is being recommended is 0.2 to 0.4 mm. Impression with a circular width less than 0.2 mm will lead to increased incidence of voids, tearing, which in turn will reduce the marginal accuracy. Coming to the tissue biotype. Now, tissue biotype also plays an important role into the gingival. The thin tissue biotype is highly scalloped, whereas the thick tissue biotype is relatively flat. A thin tissue biotype, in the thin tissue biotype, the overlying soft tissue is delicate and friable. Therefore, care should be taken to avoid any injury to the soft tissues. A thin retraction cord is used in most cases, and it should not be retained for more than 15 minutes because a thin tissue biotype reacts readily to the insults by gingival recession. Whereas for the thick tissue biotype, the retraction can be more readily accomplished. Also, the thick tissue biotype is comparatively resistant more to the gingival recession, and it reacts to any insult by pocket formation. Coming to the types of gingival retraction. The types of gingival retraction are two. That is, first, lateral and vertical. The lateral retraction, it displaces the tissue away from the tooth so that adequate bulk of the impression material is present between prepared tooth and the gingival margin. Whereas vertical retraction, it exposes the unprepared portion of the tooth apical to the finish line. Now, the retraction cords, based on the configuration, they are broadly classified into knitted cords, braided cords, and loosely woven cords. Whereas, based on the surface finish, they can be waxed or unwaxed. Based on the chemical treatment, they can be plain or impregnated. Based on the number of strands, they can be single or double string. Based on the thickness, they are color coded as black, yellow, purple, blue, green, red, where black, that is 000, is the extra small thickness. Now, the extra small thickness 000 is particularly useful in the anterior region. Also, it is anterior and it is used for a double cord technique. Whereas the yellow retraction cord, that is the 00 retraction cord, is used when the gingival tissue is delicate and friable. Whereas purple retraction cord, that is size 0, it is particularly used in the lower anterior tip. It is also used for the double cord technique. Whereas blue retraction cord, this side number 1, is used to displace the gingiva away from the tooth. Whereas green and red retraction cord are used when a thick tissue biotap is present and it requires more amount of pressure for the displacement of the gingiva away from the tooth. Coming to the criteria for gingival retraction material. Now, there are three main criteria for gingival retraction material. That is, first, it should have an effective gingival displacement along with control of the hemostasis and the fluids present. Also, there should be absence of any irreversible tissue damage, and it should not produce any harmful systemic effect. Coming to now we'll see each retraction cord in detail. Coming to braided cords. The braided cords have a consistent and high weave and a tight weave, which makes them resistant to separation. Also, it absorbs the medicament efficiently. Now, for packing of the braided cords, both smooth and serrated cord packing instruments can be used. Now, a larger diameter braided cord should be avoided because it tends to double up, which makes the automatic placement of the braided cord into the gingival sulcus difficult. Coming to knitted cords, the knitted cords are easy to place and expand when they are wet, which makes them easy to insert in the sulcus. Smooth cord packing instrument should be used for the knitted cord. Use of a serrated cord packing instrument will tend to lift the cord during the placement. Now, when plain protection cord is used for the sulcus enlargement, it physically pushes the gingiva away from the tooth. Now, the effectiveness of this is limited because there is the use of pressure alone. However, it does not have proper fluid control also, as it does not control the hemostasis. Therefore, by combining the chemical action of the agents along with pressure packing of the retraction cord, the gingival enlargement of the sulcus along with the control of hemostasis and fluids can be obtained. That is the chemico-mechanical method. Coming to the chemico-mechanical retraction cord. For the chemico-mechanical retraction cord, two types of hemostatic agents are basically used. First one is the vasoconstrictive agents and second one is the astringent agents. The vasoconstrictive agents, it acts by constricting the peripheral capillaries. The example of this is adrenaline and noradrenaline, whereas astringent agents, they inhibit the plasma protein. The astringent agent act by decreasing the cell permeability, which in turn controls the moisture in the peripheral tissues. The example of it are aluminum fluoride, aluminum sulfate, ferric sulfate. Now, what are the commonly used chemicals for impregnating the retraction cord? They are epinephrine, aluminum sulfate, aluminum potassium sulfate, aluminum fluoride, ferric sulfate, zinc fluoride, tannic acid. Also, nasal and ophthalmic decongestants can be used. Now, coming to each one of them. Firstly, aluminum sulfate and aluminum potassium sulfate. They act by precipitating the plasma proteins. The aluminum sulfate and aluminum potassium sulfate are a good hemostatic agent and they produce minimal post-operative inflammation. However, they have a disadvantage that if it is used at a higher concentration, it might produce necrosis. Coming to aluminum chloride. Aluminum chloride is the least irritating of all the medicaments that are used for impregnating the retraction cord. Also, it provides adequate hemostasis and it has no systemic effects. However, a vital shortcoming of aluminum chloride is that it interferes with the setting of polyvinyl siloxane and polyether impression material. However, it can be overcome by thorough rinsing and removal of the residues prior to impression making. Coming to ferric sulfate. Ferric sulfate, because of the presence of iron, it stains the gingiva to yellowish brown color. So it stains the tip. Now, ferric sulfate is highly acidic, so it leads to removal of the peripheral smear layer. Therefore, it can lead to increased post-operative sensitivity. Also, it can affect the bonding of the self-etching adhesive due to the removal of the smear layer. However, the advantage of ferric sulfate is it achieves good hemostasis. Whereas coming to zinc chloride. Now, zinc chloride leads to permanent soft tissue injury. Therefore, zinc chloride is not recommended. Coming to tannic acid. Tannic acid is less effective as compared to that of epinephrine, but it has a very good tissue recovery. Coming to the now various nasal and ophthalmic decongestants are also used for gingival retraction. That they are phenylephrine hydrochloride, oxymetazoline hydrochloride, and tetrahydrozoline hydrochloride. Now, studies have reported that phenylephrine hydrochloride shows gingival displacement comparable to that of epinephrine impregnated cord, whereas oxymetazoline hydrochloride and tetrahydrozoline hydrochloride show gingival displacement 37 times more than the epinephrine impregnated cord. Coming to the use of epinephrine as a impregnant for the retraction cord. Now, epinephrine provides adequate hemostasis along with fluid control. However, the use of epinephrine is controversial because now the amount of epinephrine that is absorbed from a 2.5 centimeter retraction cord being placed for a period of around 10 minutes is around 71 microgram. Now this dosage is 1/3 the dosage of the maximum permitted limit for a healthy adult individual, whereas it is twice the dosage recommended for a cardiac patient, that is 0.04 milligram. Therefore, the use of epinephrine therefore the use of epinephrine in a sulcus with in a gingival sulcus with active hemorrhage or placing a cotton cord impregnated with epinephrine can lead to increase in the heart rate, increased blood pressure, rapid respiration, and anxiety. Therefore, epinephrine is contraindicated in patients with cardiovascular diseases, hypertension, hypothyroidism, diabetes, and patients with on-ganglionic blockers and antidepressants. Also, epinephrine should be used in caution also in the healthy individuals, because the maximum permissible limit can exceed easily if the retraction cord impregnated with epinephrine is placed on multiple abutments or the multiple impressions are repeated. Now, a study was done to evaluate the vasoconstrictive retraction agents on the primary human gingival fibroblast. The nasal and ophthalmic decongestants, that is phenylephrine hydrochloride, tetrahydrozoline hydrochloride, and oxymetazoline hydrochloride, were evaluated for effect on the human gingival fibroblast cells. And the study showed that the novel experimental gels were biocompatible with the periodontal tissues, and they can be considered as the new vasoconstrictive agents as compared to the conventional solutions available. Now, what are the armamentarium required for the placement of a retraction cord? They are evacuator, scissors, cotton rolls and pliers, mouth mirror, explorer, Fisher cord packing instrument, plastic filling instrument, retraction cord, hemostatic agent, and appendage. Coming to the method of placement of cord. Firstly, the cord is dispensed from the dispenser using a sterile cotton plier. Around 2 inches of cord, that is around 5 centimeters, is cut, and it is holded between the index and the index finger and the thumb, and the cord is twisted to make the cord tight and of minimal and to reduce the diameter. A loop of the cord is formed and is placed around the prepared tooth. The placement of cord is begin from the mesial aspect of the prepared tooth. Also, the cord is tucked into the distal aspect to hold it in position while placement of the cord. During placement, the pressure should be directed towards the cord that is already in place. Now, directing the pressure away from the cord already in place will tend to lift up the placed cord. Okay, and now occasionally holding of the retraction cord by one instrument on one end may be necessary while the retraction cord is being placed on the other end. Also, the retraction cord should be placed at an angle to the root surface to facilitate subgingival placement of the retraction cord. Now, what are the techniques for gingival retraction? The techniques of gingival retraction are single cord technique, double cord technique, infusion technique, and every other tooth technique. Coming to first, single cord technique. The single cord technique is indicated when retracting the gingiva for obtaining impression of 1 or 3 prepared teeth. It is indicated when the gingival tissue is healthy, especially when the prepared margins are at or below the level of the gingival tissue. So a single cord of the largest diameter that can be placed in the gingival sulcus is selected. The cord is impregnated with a chemical agent and then placed in the sulcus for a period of 8 to 10 minutes. to provide adequate lateral displacement along with hemostasis. The cord is then wetted before removal because removal of a dry cord from the gingival sulcus will lead to trauma to the inner epithelial lining. Now, the disadvantage of the single cord technique is single cord technique can lead to thin margins near the thin impression material margins near the placement because of the tissue relapse. Whereas coming to the double cord technique, the double cord technique facilitates better recording of the margins uh, as it prevents the relapse of the tissue over the small retraction cord that is already in place. Now, in the double cord technique, a smaller diameter cord, non-impregnated, is placed in the gingival sulcus. Over that, a larger diameter cord, impregnated with the chemical agent, is placed. Prior to impression making, the larger retraction cord is removed, and the impression is made with the smaller diameter cord in place. Now, the double cord technique is primarily is used for both the single tooth and the multiple tooth impressions. However, it is of advantageous for the multiple teeth impression because the gingival clavicular fluid can seep over the prepared cervical margins of the last tooth prior to the impression making after the cord removal. Coming to every other tooth technique. Now, while making impression in the anterior region, extreme care should be taken to prevent any injury to the gingival tissue, as any injury to the gingival tissue can lead to gingival recession. So, placement of the retraction cord on all the prepared teeth might result in strangulation of the interdental papilla, leading to loss of the papilla and creating anesthetic black triangles. So, these pictures demonstrate every other tooth technique. Firstly, polyvinyl siloxane index of the prepared teeth is made. The index is cut into smaller indices and the retraction cord is placed on the alternate teeth. And then a final pickup impression is taken. Coming on to the infusion technique. The infusion technique uses a specialized Denture infuser device. It uses astringent agents, that is ferric sulfate 15% and 20%. 20% ferric sulfate is recommended because of the decreased acidity and less chances of removal of the smear layer. Now, firstly, a Denture infusion brush impregnated with the hemostatic agent is moved 360 degrees in the gingival sulcus. After the hemostasis is achieved, the retraction cord with the ferric sulfate solution is placed, and after a period of 1 to 3 minutes, from air water spray is applied to remove the residual column. Now, the disadvantage of this technique is the retraction cord is placed in the gingival sulcus for a period of 1 to 3 minutes. This might not produce the effective lateral displacement. Also, because of the use of the ferric sulfate, it leads to staining of the gingiva to the yellowish brown color. Now, coming on to the non-invasive advances. The use of the conventional retraction cords, be it mechanical or chemico-mechanical, it is well established because of the increased predictability and effectiveness. However, the use of the retraction cords is time consuming. Also, because of the pressure applied to is uncontrolled, it can cause damage to the epithelial attachment, which can lead to direct trauma. Also, it can also cause gingival bleeding and gingival dissection. Therefore, new non-invasive advances have been introduced with several advantages over the conventional techniques. The new advances introduced are expansile, magic foam cord, Merocell, gel cord, viscostat, gingitrack, and staple. They have the advantages in that they have decreased intraoperative time. They also increase the patient comfort, and these techniques are minimally invasive and the pressure applied is controlled. Coming to the first non-invasive technique, that is expansile. The expansile retraction paste, it applies very light pressure, that is around 0.1 to 0.1 Newton per Newton meter. Therefore, it causes no harm with the epithelial attachment. Now, the expansile retraction paste, it consists of kaolin and aluminum chloride, water, oil of lemon, and colorant. Aluminum chloride has an astringent action, which helps in controlling the bleeding in the gingival sulcus, whereas kaolin causes hygroscopic expansion, which helps in the lateral displacement of the gingival tissue away from the tooth surface. Now the disadvantage of expansile paste is paste is not useful in recording the subgingival margin accurately. Also, the tissue relapse after the expansile paste placement is comparatively rapid. Coming to the video. Because of the minimal pressure applied, expansile paste does not cause any damage to the epithelial attachment. The expansile paste is available in the form of an injectable matrix. The injectable matrix is used and the paste is injected over the prepared tooth. After the material is injected, it is left in place for a period of 1 to 2 minutes to achieve adequate hemostasis along with gingival displacement. After a period of 2 minutes, the material is rinsed and the tooth preparation is dried and the impression is made. Expansile paste has an advantage to easy removal. It does not resume the bleeding. Also, because of the minimal tissue injury, there are decreased chances of gingival recession. Now, a study was done to evaluate the gingival displacement done by the cord and the cordless system and the effect on the gingival crevice. So, 4 groups were studied. 2 conventional gingival retraction cords. One is the ultra-pack, that is knitted cord impregnated with epinephrine, and group 2 is the Siltrax cord, that is the braided cord impregnated with aluminum sulfate. They were compared with the cordless system, expansile and Traxodent containing 15% aluminum chloride gel. The gingival sulcus was photographed every 20 seconds from 0 to 180 seconds after removal of the cord and the cordless system, and the gingival bleeding index was recorded at an interval of 1, 7, and 10 days. The results of this study showed that all groups showed a sulcal width greater than 0.22 mm up to 60 seconds after the removal of the displacement materials. Among all groups, the expansile showed the fastest closure of the gingival sulcus. So the study concluded that up to 60 seconds, both the cord and the cordless technique were equally effective. However, the cord group showed a greater amount of displacement than the cordless group, and the cordless material led to a decreased frequency to the gingival index. Now, the clinical implication of the study was that up to a period of 60 seconds, both the cord and the cordless material were equally effective. However, after a period of 60 seconds, the cordless material led to a decrease in the circular width. Therefore, the cordless technique, particularly the expansile, was recorded for single tooth impression, whereas it is not recommended for the multiple tooth impression. Now, another study compared 4 cordless gingival displacement systems, that is Traxodent, expansile, expansant, and 3M retraction. They contain 15% aluminum chloride gel. Then 3M ESP and expansant are available in the form of unit dose capsules, whereas expansile is available in the form of special dispensing gun, and Traxodent is available in the form of a syringe with the changeable needle tip. So the gingival sulcus of the prepared teeth were scanned before and after the application of the cordless gingival retraction material, and the images were superimposed to evaluate the gingival displacement. The results of the study showed that there were significant differences between the 4 tested systems in recording both the vertical and the horizontal gingival displacement. The expansile, expansant, and 3M retraction, it produced the gingival displacement more than 200 micrometer, whereas Traxodent provided the least displacement, that was around 100 micrometer in both the vertical and horizontal dimension. Now coming to another advancement, that is the magic foam cord. Magic foam cord, it is an expanding polyvinyl siloxane material. The setting reaction produces a hydrogen gas, which leads to expansion of the material. Now, magic foam cord can be easily placed into the sulcus of the prepared teeth, and the patient is asked to bite over the comprep or the putty index. The patient is advised to maintain pressure for a period of around 3 minutes. and then the material is removed, rinsed, and the impression is made. Now the advantages of this technique are it is less traumatic than the retraction cord, and there is easy removal of the material from the sulcus. Also, there is adequate working time. However, the disadvantages are that it does not contain any hemostatic agents. Therefore, adequate hemostasis is not provided. Also, it is less effective on the subgingival margins. Coming to Merocel. Merocel is a synthetic polymer, that is polyvinyl acetate. Now they are cut into 2 mm strips and they are easily shaped and placed into the gingival sulcus. Interim provisional restoration is placed and the patient is advised to bite on it for a period of 10 to 15 minutes. Now Merocel contains a sponge-like porous structure. This structure tends to absorb the oral fluids from the gingival sulcus and tends to swell up, which expands the gingival tissue away from the finish line. Also, adequate fluid control is achieved. However, they do not contain any hemostatic agent, so it does not achieve adequate hemostasis. Coming to the gel cord it uses 25% aluminum sulfate gel. It offers adequate hemostasis along with control of the circular fluid. Now in gel cord technique, the viscous gel remains in place for the duration of the procedure, and this makes the cord packing easier because of the lubricating action. Now the aluminum sulfate gel is applied to the sulcus. Once the hemostasis is achieved, the gingival retraction cord is packed through the gel. After a period of 8 to 10 minutes, the retraction cord is removed. The tooth is rinsed and dried prior to impression making. Coming to viscositide clear. Viscositide clear uses 25% aluminum chloride gel. Now, aluminum chloride gel is the least hazardous to the gingival tissues as compared to any other chemical agent used for impregnating the gingival retraction cord. So, it is particularly designed for the anterior aesthetic regions. The aluminum chloride gel is put into the gingival sulcus. After the hemostasis is achieved, the gingival retraction cord is placed. And after a period of 8 to 10 minutes, the retraction cord is removed and this area is rinsed and the impression is made. Coming to gingitride. Gingitride uses medium viscosity polyvinyl siloxane material impregnated with 15% aluminum potassium sulfate, that is Al. Now in the gingitride impression material, the polyvinyl siloxane material is injected around the prepared tooth. Patient is asked to bite on the gingival cap and pressure is maintained for a period of 2 to 3 minutes, following which it is removed and the tooth preparation is dried. Now the advantage of gingival is that it is compatible with all impression materials. Also, there is easy removal. It does not cause any tissue, any bleeding or trauma to the tissues. It is indicated for making single preparation retraction. Coming to stay put. Now stay put is a stay put retraction cord has a copper wire core over it and the nylon fibers are wrapped. Also, the outer layer is made of a braided cotton. The advantage of stay put is that because of the presence of the copper wire, it is easily moldable and stays in the gingival sulcus once it is applied. The stay put has an advantage of both the braided cords along with the impregnation of aluminum chloride, which helps in achieving adequate hemostasis. Now, a study was done to evaluate the lateral gingival displacement obtained by two retraction cords, that is stay put, and conventional retraction cord, that is ultra-pack. After the gingival retraction was done, the impressions were made, the dies were poured, and the cast were retrieved. The cast were sectioned buccolingually to measure the lateral gingival displacement using microscope. This picture shows the microscopic view of the section die of the stay put retraction cord, and this shows of the ultra-pack retraction cord. The study concluded that the mean gingival retraction in the stay put system was higher than that of the ultra-pack. However, the differences between the two systems was not statistically significant. Coming to no-cord system. Now, no-cord system is a one-step self-retracting impression system. It uses two pastes, that is the no-cord wash paste, which contains 15% aluminum potassium sulfate, and the tray material that contains medium viscosity polyvinyl siloxane. So firstly, the no-cord paste containing aluminum potassium sulfate is injected around the prepared tooth, and then medium viscosity polyvinyl siloxane tray material is placed and impression is made. Now, a study was done to evaluate gingival displacement obtained by 3 techniques, that is, conventional retraction cord chloride compared with that of no-cord polyvinyl siloxane and aquasil material. The intraoral scanner, coming to the methodology, the intraoral scanner and vernier caliper were used to study and compare the dimensional accuracy of each dye obtained. And the dyes were sectioned to evaluate under the optimal microscope to measure the amount of the gingival retraction obtained. Coming to the results, it was seen that the amount of gingival retraction obtained by using retraction cord impregnated with aluminum chloride was maximum as compared to that of no-cord polyvinyl siloxane followed by aquasil. Also, all 3 gingival displacement techniques provided a gingival displacement more than 0.2 mm and all 3 materials were dimensionally accurate. Now, a systematic review was done to evaluate the efficacy of conventional cord versus cordless techniques for the gingival displacement. It compared gingival retraction cord impregnated with aluminum chloride, ferric sulfate, and 2 of the articles used saline for impregnating the retraction cord. Whereas in the cordless technique, Expansile, Magic Form, and Marocel were compared. The results of the systematic review showed that the cord technique resulted in an increased displacement as compared to the cordless technique. And amongst the cordless material tested, Expansile was the most effective. However, during the insertion of the retraction cords, the pressure applied may damage the epithelial attachment, which can lead to gingival bleeding and direct trauma to the sulcular epithelium, which in turn can cause recession. Now, another study evaluated the effect of the retraction agents and the cleaning on the polymerization reaction of the elastomeric impression materials. 3 impression materials, that is polyvinyl siloxane, panacyl, express, and monophase polyether impression material were evaluated. 3 different retraction materials, that is 3M ESP, dryers, expansil, containing 15% aluminum chloride gel were used, and 2 cleansing techniques, that is cleaning of the prepared tooth using water and using hydrogen peroxide were evaluated. The study concluded that all the retraction materials used showed low potential for polymerization inhibition for the elastomeric impression material. Also, the study recommended that Expansile should be cleaned using hydrogen peroxide prior to impression making, whereas 12 and 3M ESPA should can be cleaned with water prior to impression making. Coming to conclusion, soft tissue management is an important factor determining the success and functioning of fixed processes. No scientific data has stated that one technique is adequate for all the cases. So, it is in the hands of the operator to carefully analyze the clinical situation and decide which technique would be best suited for the patient. Also, selection of the hemostatic agent should be highly precise, and if possible, epinephrine should be avoided. And also, the recent techniques should be encouraged. These are the references. Thank you.